All right, welcome everybody as you are coming in here. Give people just a second to come out of the waiting room. Um, Welcome to our first ever training of this type. I'm Alexis Madrigal. I'm one of the co-leads of the project, and I'm going to be joined on this call by another co-lead, Erin Kassane, as well as the real experts in how to use this federal data, Kara Scheckman, Dave Lowe. This is going to be the first in a series, and of course it's happening because, as I'm sure you all know, on March 7th, we will be ending compiling data from states. The project will still be around for a couple months after that, working largely on accountability and putting together things like this just so that our data users can do the kinds of projects they need to do. Can I get the next slide, Glenn? You're going to get two federal data sets this time. So we're going to tell you what we've learned about them, and then you're going to get kind of quick tutorial. You can put questions into the chat anytime. We're going to moderate those. Erin's going to ask those at the end of both sessions. So wait till the very end. You got to stick around if you want to get your questions answered. And we'll answer as many as we can, but we imagine there will probably be more than we can get to. Again, we are not part of the federal government. Some people have been confused about that at times. These are peer trainings. You know, we just want to help, and we feel like it's our responsibility to responsibly transition out of collecting data into this new phase. And if you, well, of course, you can use what we're telling you. This is not really an official on the record thing, and we would appreciate if you would come to us if you actually want to talk about this data in a way that's not about just helping you to do stuff, which is really what these sessions are all about. With that, let's go to Dave.
Well, actually, we have one more thing.
Sure. This is the data that we've offered, and we're ending the collection of all of these on March 7th. Today, we're just going to talk about hospitalizations first with Dave, and then testing with Kara, and we'll get to the rest of these through time.
Great. I think you can bump ahead 2 slides, Glenn. And now we're into the hospital side.
Okay, great. Hi, everyone. I'm Dave, and I am a co-lead in data science and data viz for the COVID tracking project, and a particular focus on hospitalization data over the last many months. So would love to tell you more about what we learned. Next slide, please. So the headline is that the CTP data for currently hospitalized COVID patients across the country is very much in line at this point with HHS's hospitalization data, HHS being Health and Human Services, the federal agency. And we see this in this chart here, which is also available on our Hospitalization Data 101 blog post that came out this week. After we adjust for definitional differences in the state reporting and a time lag of approximately 1 day between when HHS puts out their data and when CTP is able to collect it 1 day later from the state dashboards across all 50 plus jurisdictions. And so you can see once we do adjust for these definitional differences, which I'll get into the next slide, as well as making that 1 day offset to match up with the HHS data, that we're under 1% difference at this point, and we've been very close for a very long time now. And so that is great news, is that it is pretty much could be a one-to-one replacement in many ways. And we'll see later in the slides that there are many more things that you can learn from the federal data. Next slide, please. Okay, so when I was speaking about definitional differences, what I really mean is that for each and every state, they choose to report in their own prioritization system, perhaps only confirmed COVID patients that are currently hospitalized, or they might report confirmed plus suspected patients, and they have different definitions for what a suspected patient might be, which we'll get into shortly. But the point is that every state gets to decide and report in slightly different ways on their dashboards what exactly constitutes a currently hospitalized COVID-19 patient. Is it just confirmed by lab testing? Is it confirmed plus suspected by some definition of suspected? And these will vary for every single state. And so you can't see every plot here, but we do have this again on the blog post, which you can view in high resolution. And we'll go into a few examples on the right here. But we can actually look at the plots of what CTP has collected from each state compared against what the federal data has for confirmed COVID-19 patients and suspected. So the two stacked bars in lighter colors, the lighter two blue bars, and actually visually gauge, well, does our CTP state data match up more closely with confirmed only hospitalizations or confirmed plus suspected hospitalizations in the federal data? Or maybe it's somewhere between the two, or maybe it's something slightly different than either of those things. And so a few examples here, Illinois on the top left and on the right-hand side. If we're looking at the dark line, that represents what we collect at COVID Tracking Project for currently hospitalized COVID patients. The lighter blue area is what the federal data reports for Illinois in terms of a suspected COVID-19 patients currently hospitalized. And then the darker blue area underneath that is the confirmed adult COVID-19 hospitalizations. And so the total height between the two lighter blue colors represents all COVID-19 patients reported by the federal data set that will be confirmed plus suspected. And so when we look at Illinois comparing CTP versus federal data here, we see that CTP state data matches up almost perfectly with what Illinois reports as, what the federal government reports as confirmed plus suspected COVID-19 hospitalizations. Looking at the bottom one, which is Maine, we again look at the blue line compared to where it falls along the confirmed plus suspected area for the federal data. And we see that in this case, Maine is reporting on their state dashboards only confirmed patients, confirmed cases hospitalized, while the federal data includes the suspected in the lighter blue above that. Florida, on the example in the top right here, also seems to be reporting just confirmed COVID patients, and in their dashboard, they actually define what they report. They define in the second line of the title here as primary diagnosis of COVID, which does indicate that these are confirmed patients, but it may be even a smaller subset than all confirmed COVID-19 patients who are currently hospitalized. And so again, to get to the definitional differences, what we've tried to do is look at all of these plots, compare them to two data sets, and then adjust for what we think is the best match between the CTP state by state data versus what the federal government is reporting in terms of confirmed and suspected patients. And once we figure out what the best match per state is, that's how you end up with the comparison of our total numbers nationwide against the federal numbers nationwide being very close to each other. The other way you can see these side by side is actually on our state cards page on the CTP website. In the bottom right, I have a screenshot. And this is actually showing for Colorado, the CTP numbers on the left card compared to the HHS numbers for these same categories on the right, where they're reported. Next slide, please. And then finally, we'll get into this more as well, that HHS is able to provide more than just state level data. They actually started providing facility level data on a weekly basis in December. And from that data set, we were able to create this map interface, which you can see interactively on that link, which shows for every facility, hospital facility, the number and percentage of COVID-19 patients hospitalized overall, as well as how many COVID-19 patients are currently in the ICU at every facility in the country. Next slide, please. So how is the HHS or federal hospitalization data collected? It's essentially collected from every single hospital facility every single day of the week. And it's been that way since July of last year. There's over 6,000 hospital facilities that are included. And the best place to reference what exactly is being collected from these hospitals, what types of hospitals, what are the definitions of what's being reported, is to look at this hospital reporting FAQ that's available on the link at the bottom left, which we'll also share elsewhere. But this will give you the most definitive details on what is expected from every single hospital in their reporting to the federal government every single day. And you can see here, I just took a few snapshots of various parts of this document, which is multiple pages long. But we are including every category hospital, essentially, that there is. And an example of the kind of detail that it goes into is this 9A and 9B for hospitalized adults, suspected or confirmed positive patients. What exactly do they mean by that? So it is lab confirmed or suspected COVID-19 patients in any adult inpatient bed, including those in observation beds, for example. And then like of that, what subset is considered or defined as confirmed only? So these are laboratory confirmed COVID-19 patients. On the right-hand side, this is another link which goes to the level of transparency that HHS is providing these days, where you can look at every single facility and the details about the facilities that report to HHS. You can see the category of hospital they are, and you can actually see over the last week how many times that week that hospital reported on every single required field. There are over 90 fields that they're reporting on every single day, and so a perfect record would be that they're reporting all 90 fields 7 days a week. And that would be indicated as 7 out of 7 for that particular field. And in total would be considered 100% reporting coverage for that facility for that week. Next slide, please. Okay, so we kind of know where the underlying data is collected, how it's collected, where it goes. From every hospital facility. Now on the other end, on our end, like where do we see this? There are many places to look at it. The most accessible and kind of well presented way to look at it, you could say, is via the CDC COVID data tracker on their county view. And so this gives you an interactive map from which you can select the state and county or metro area. And then I just took a screenshot here to show you on the map, you have this drop-down menu, which lets you look at the change over time, change from the prior week across these types of metrics. So this is new admissions of confirmed COVID-19 patients, percentage of staff beds used for COVID-19 in that county, percentage of staffed ICU beds, et cetera. And once again, these are metrics that were either directly pulled from what was reported by every facility and then aggregated to the county level, and or they could be calculated from various metrics reported. And so in the case of the percent staff beds used for COVID-19, that would be the number of COVID-19 patients in those beds divided by the total number of staff beds reported for that county by every hospital within that county. And then on the left-hand side, there you can also see the kind of trend over time across these key metrics, like how many newly admitted COVID-19 patients there are every day, taken as a 7-day rolling average, the percentage of beds used in this county, the percentage of ICU beds used by COVID patients in this county. Next slide, please. Another place you can see this information in a different way and with different types of metrics is in what's known as the community profile reports, or CPR, as it's often referred. This exists in two forms. There's a PDF format, and then there's an Excel spreadsheet format. They both have the same information, but the spreadsheet is, of course, more useful if you're trying to dive into the exact numbers. The PDF be more useful as a presentation medium. And I just pulled a few slides. There are many things covered in this report. I highly encourage you to look through it carefully and extensively. These are some of the ones that cover some of the hospitalization metrics that are reported. And so we can see for every single HSA or hospital service area in the country, the number of adult COVID patients in the ICU over the past 7 days from this week to the prior week. You can see by state the trend in ICU bed capacity in the bottom left. On the top right, you can see at the CBSA level, which is a grouping of multiple counties that form a larger metropolitan area. You can see various metrics across various population categories for hospitalization as well as other things. And then again, the bottom right here just shows you the spreadsheet version of that. But everything you see in the PDF format is also available in the dozen or so tabs on the spreadsheet. Next slide, please. Similarly, you can see this on the state profile report, or SPR. And this is divided up into state by state PDFs only. And it again uses all the same underlying hospitalization data collected by HHS, presented in a different way. And these are generally geared towards state governors, as well as governors' offices and other state level or local officials. And here I also pulled some relevant slides. These are just a few of many pages. But for example, we see the total number of hospital admissions per week. We also see data that's reported by facilities regarding their PPE supplies, different types of categories here, from eye protection to gloves to masks, etc. And also spatially, the change in the number of admissions by county over time. Next slide. Okay, so those first couple of resources were mainly presentation mediums. They're meant for communicating high-level information. If you wanted to dig more deeply into the analysis of the data, the next couple of things I'm going to cover are spreadsheet-based, essentially. They're CSV files and allow you to explore the underlying data sets that drive all of the presentation materials beforehand. And so these all live on healthdata.gov. These are the search results or the names you can look at to find them. The best way I've found is just to search for them via that beginning name, or if you have the direct links, you could just go there. But there are three. There's the state time series, there's the state daily update, and then there's a facility level time series. This information is also available on our one-on-one hospitalization blog post. Next slide, please. And then finally, in terms of metadata, this would be data about the data regarding how many hospitals are reporting, what is the overall kind of performance of reporting across the country. You can go to this site, which is the HHS Protect Public Data Hub. There's a lot of background context about what it is, like where the data comes from, where it sits, who's reporting what. And so I encourage you to take a thorough browse through the site as a whole. I covered a few screenshots here that show you some of the key things you can find there. On the bottom left shows a graph over time, a line chart that tells you the percentage of hospitals that are reporting every single metric every day. If you look at the red line, this is number 4 in the list here. It's the percentage of hospitals reporting 100% of data every day. You can see that there's been a dramatic improvement since the beginning of October in this metric. And so this is, again, every hospital reporting almost 90 columns of data every single day of the week. You can see that about 96% of hospitals are doing this in the most recent weeks. And it's been in the 90s range since November, which is quite a feat. And then on the right, you can dive into every single hospital and look for that particular hospital, their category of hospital, the number and types of metrics they are reporting 7 days a week, etc. All the details are available for you there. Next slide, please. Okay, so this is just to give you a quick summary of what's what that we just talked about. So the first 3 we covered were the CDC data tracker, the community profile report, the state profile report. These are all presentation purpose files and resources. The time intervals I don't need to read out loud, but essentially these are covering things at the county or above level, often updated daily or weekly in PDF or website formats. The bottom 3, which we'll talk about a little bit more, is related to deeper analysis. These are available at the daily or weekly levels, and these are often at the state or facility level. And again, because these are meant for analysis, you are likely going to require something like Google Sheets or Excel or Python or R to analyze the much heavier files. The biggest one here being the facility level time series, which is 130,000 rows and 90 columns. Although I would really recommend just starting with the state level time series, which Google Sheets, Excel will handle quite easily. It is readable and will give you most of the things you're looking for at the state level immediately. And then dive into the facility level once you're comfortable with the state level data. Next slide, please. Okay, so when we're talking about the state level and the facility level time series data in analytical sense, these are perhaps the closest equivalents between what COVID tracking project provides as fields and what the state and facility level data provides. If you use this API or have familiarity with how we name our data fields, hospitalized currently is just all patients currently hospitalized as reported by states, by COVID patients that is. And this translates into actually 4 distinct categories in the state facility level HHS data. You can look for confirmed and suspected COVID patients that are adults. You can look for adult confirmed only. And by subtracting one from the other, you can also derive suspected only adult COVID hospitalized patients. Then you also can find pediatric confirmed and suspected, et cetera, et cetera. At the state level, this is available daily. And it is, each row represents a single day. At the facility level, it is available on a weekly cadence, and each row represents the weekly average of the daily reporting. And so that is to say, if a hospital is reporting 100 patients, adult COVID hospitalized patients that are confirmed across a week, then that averages out to 100. But if there's fluctuation during the week, you're not going to get the day-to-day granularity. You're only going to get the average across the whole week. And the reason they did that is to protect patient privacy at the facility level because of how granular it is. The other thing that happens at the facility level data is that it is a smaller subset of the state data. The state data represents all hospitals except for, well, actually it does represent all hospitals that report. At the facility level, it's most hospitals except for psychiatric and rehabilitation hospitals, which are considered lower priority, so they're not included. The facility also doesn't include the DoD military hospitals, Veterans Affairs hospitals, and hospitals administered by the Indian Health Services. And so in numbers, what we're saying is the state level data represents about 6,000 hospital facilities, all of them across the country. And the facility level data represents about 4,900 facilities, a smaller subset. And the numbers reported there are averaged out across the week as opposed to a daily number. And then finally, at the bottom 2 here, you also have the kind of same respective data columns for ICU hospitalizations. So next slide, please. So that's kind of the kind of drop-in replacement, you could say, or like choose your own adventure in terms of getting to currently hospitalized COVID patients as well as currently in ICU COVID patients that are most similar to what COVID tracking project provides. But there's so much more data that's available in the HHS data sets. The first and maybe biggest one is that having the facility level time series gives you the additional granularity you need to aggregate things however you like. You can choose to look at individual facilities. You can look at it by zip code. You can look at it by county. You can look at it by multiple counties. You can look at it by these things known as hospital service areas and hospital referral regions, which represent catchment areas for patients that are irrespective of administrative boundaries, like a county line. You can do whatever you want there. And that gives you a lot of analytical potential that didn't exist before, and there was no way for CTP to collect that level of data from every single hospital. In addition, you also are getting the denominator in many of these cases. You're not just getting the number of COVID hospitalized patients, you're also getting the total number of beds that are staffed to the total number of ICU beds that are staffed. You're also getting the total number of ICU and inpatient beds that are occupied, regardless of whether they're by COVID patients or not. And so from that, you can calculate the percent occupancy of these beds. It's also standardized in the way it's broken out between confirmed and suspected patients, as you've seen. The other entirely new category of data that we don't collect and couldn't collect is admissions data. So rather than just looking at how many patients are currently in the hospital, what's the current census of patients every day, this admissions data tells us how many new patients were admitted every single day of the week across time. And in many ways, this could be a cleaner metric and a more real-time metrics, because you're just accounting for who is entering the hospital without worrying about how long a patient stays there, how quickly they get discharged or moved into another tier of care. And so if you were trying to understand the velocity of the pandemic in a local area, looking at admissions at the facility or county level or HSA level, maybe even a cleaner signal than looking at current hospitalizations. Again, at the facility level, these admissions data are broken up by confirmed and suspected, but also by age brackets. So from pediatric, so 0 to 18, then 18 and 19, and then from 20 to 30, 30 to 40, et cetera, all the way up to 80 plus. This admissions data is broken out by confirmed and suspected cases. You also have ED visits data. You also have influenza-related hospitalizations, et cetera. And so I highly encourage you to look at the data definitions, which is available within each healthdata.gov page for each data set, and carefully understand what's available, how the naming conventions work, what it doesn't mean, et cetera. And there are a lot of resources out there and that we've shared that allow you to do that. So that's what I got. Next slide, please.
We're going to go to Karen in just a second, but I just wanted to say that Dave has been working on and with this data for many months now, and is responsible for really so much of our understanding about how this data set works, and with pushing on the federal government to improve its many quirks, pre-processing it for our use on the site, and just so many thank yous to Dave, and hopefully you'll get a chance to hear from him at the end in some Q&A. And let's go over to Kara, who has been working for even longer with federal testing data.
Thanks, Alexis, and hello, everyone. So my name is Kara, and I co-lead data quality here at the COVID Tracking Project, and I'll be talking a little bit about the federal testing data. So in order to understand some of the similarities and differences between the COVID Tracking Project data and federal testing data, I thought it'd be helpful to just start with a little bit of a review of what we publish in our testing data. So we collect test data from state health department websites. And what that means is that our data is a mix of a lot of different kinds of data because it depends on what states choose to make public. So the test types of our data, ideally we like to capture RT-PCR tests, but some states will combine other types of tests in those totals, like antigen testing. So sometimes we have antigen test data included in our test types. Our data, it comes in multiple different units. The big division is between counting the number of people tested and the number of tests that have been conducted, because a person can have multiple tests. So that will cause big differences between states counting people and tests. Right now, 2 states still only reporting people. We collect data by date of report. So when a state posts, basically when a state chooses to release information about the tests that has come to its department, as soon as it counts them and puts them on its dashboard, we report them. What this means is that if a state receives a big backlog of tests and posts that all on a given day, it'll show up as a spike in our curve. There are other different dating schemes that go back and assign those tests to their proper date, but we've been unable to collect them because not all states make that data available publicly. And finally, in terms of historical data, we offer data going back in our total test results field between January and March. But depending on what the state has made available publicly, those will be in different units. And sometimes states will be making tests, our preferred unit for total test results, available only at the top, but they won't be providing that data back from January to March. So a state's time series in our data could be people, even if the state is providing specimens or encounters, which are the test units. The federal data is a little bit differently shaped. So where we collect data from state dashboards, the federal government gets data submissions directly from states in most states, and in 5 states gets data directly from laboratories, and we'll be going into what that means for the data in a little bit. But in terms of the properties of the data, it's much more standardized than ours. So the federal data is RT-PCR testing only. The federal government also receives antigen data from states, but doesn't publish it. Antigen testing in general is very underreported. So if we had to guess why they don't publish it, it's probably because it's not a comprehensive picture. And many states that do publish it say that it's not a comprehensive picture on their dashboards. The test unit is specimens in every state. The dating scheme is date of specimen collection or date of result. So this will be the date that the test was conducted or the date that the test received a result. And they switch between those depending on what is available for each test, whether they can backdate them. But the upshot is that there's not really any big data dumps in the federal testing data curves. They're much smoother. And finally, historical data availability. You can access state level data back to March 1st, 2020. There's also county level data, which is a level of granularity beyond what we offer, but they don't have time series that are downloadable and accessible for that. But you can access some county level testing data. So where can you get this data? So there are 4 different places that you can get this data. The CDC, a lot of them are similar places to where you can get the hospital data. The CDC COVID data tracker, the HHS posts a state level time series, and also the community profile reports that Dave talked about. And finally, the Centers for Medicaid and Medicare Services posts a data set of county level test positivity. I'll go into the details of what each of these are in a second, but I think one really important thing to know about them, and which isn't crystal clear from the documentation of this on the federal side, is that all these data sets are coming from the same place. They're coming from a program called the COVID Electronic Laboratory Reporting Program. And that means that if you see a footnote or documentation in one of these data sources, you can extrapolate it to others of the data sources. That can come in handy because some of these data sources are much more, or some of these data products are much better footnoted and documented than others. So that is a useful thing to keep in mind when you're working with it. That said, even though they're the same, they're also different. They're different products on top of the same data, and each of them is useful to different kinds of users, and you have to kind of get to know each of their quirks. So I'll go over what each of these has to offer. So the CDC COVID data tracker, the main virtue of this data tracker is that it's effectively a dashboard. It lets you explore testing trends at both the state and county level. You can see on a map things like comparisons of tests per 100K or test positivity between states. And you can see time series actually for county level data, which is the only place that you can see this. It's not downloadable. You can't get exact numbers, but you can see the trajectory of testing in any given county if you click on the county. In terms of downloadable data that you can get from this source, there are tables at the bottom of the state level time series or the state level map where you can download the state level testing data for the last 7 days, 30 days, and all time total tests. This is probably not the best place to go for machine readable data, but it's there as an option if you want it. One virtue of this is that it is updated daily, which the other main source of state level data is not. So that is useful. So the second big source of testing data is the community profile reports that Dave mentioned. So these are both a PDF and a downloadable Excel spreadsheet that are made available daily and have been made available by the HHS since mid-December. They feature 7-day total test and positive test count, as well as test positivity at the state and county level. And on top of that, they offer a lot of different analyses that have sort of guided the federal response throughout the pandemic. So you can see things like county risk levels calculated on top of testing, cases, deaths, hospitalization indicators. There's also some nifty data points that we haven't seen comprehensive reporting around from states, like test turnaround time in these reports. So that's useful data. And you can download it as an Excel file in addition to a PDF file. The Excel is generally what we look at. It's another thing that makes it very, very useful and something to keep in mind about it for dealing with the testing data in general is that the community profile reports have really great documentation of what's going on with the testing data. And there's two main places you can find these in the Excel downloads. You can go to the data notes tab, and this has a section called dynamic data notes. And basically the HHS will put here if a state, for example, didn't submit testing data in the last few days, so its 7-day average may be unrepresentative, or if like a state is processing a backlog and they expect to see some fluctuation in the more recent numbers as those tests are dated back. These notes, they're the only place you can get them from the federal government, and they're very, very useful. There is also a high visibility data notes tab section if you go to the user notes tab, which is right when you open the document, and that puts some of the implications of these for the data. It spells out like what you can and can't do with it based on some of the shortcomings, and we'll be going into those in a second. But those are, it's an important place to look when you're working with this data. So the third source of testing data from the federal government, and probably the friendliest for machine readability, is the state level time series that the Department of Health and Human Services posts usually kind of daily. Sometimes it takes 2 or 3 days between an update, but the data is provided in a daily format. So we have testing totals for each day, and it's broken down by positive, negative, and inconclusive tests for each day and per state. This data is delayed by the HHS a few days to avoid fluctuation from backfilling. So because the tests are dated by specimen collection or date of report or date of result, the top of the time series can fluctuate a little. So they artificially suppress it and draw data from, like say on February 14th, they might draw data from February 10th. And a really valuable feature of this data is that it offers historical data back to March 1st, 2020 in every state. So you can actually see the time series. And if you're thinking about, alternate data sources to CTP data and ways to get continuous data, the HHS data can offer that. There's also a JSON like API that you can query to get metadata about like the CSV that they post and like the CSV link. So that makes it easy to work with in Python or our other packages for sort of computational analysis. And then the final data set is posted by the CMS, and it has test positivity figures for each county taken as a moving average over 14 days of data. And it goes back to late August. So this file has been updated since late August. It was posted for the purposes of informing long-term care facilities about what they should do for their testing surveillance programs. So they have different, based on the test positivity, the frequency of testing was advised or is advised at a different rate. And more recent reports also have total tests for the past 14 days, the raw numbers in addition to the test positivity numbers. So with those 4 sources in mind, all coming from the same underlying data set, just a few words about some of the caveats of that data that are really important to keep in mind when you're working with testing data from the federal government. So probably the most important thing to know is that there are 5 states and 7 there are 5 states where state level data is very incomplete in the federal data set, and there are 7 states where county level data is very incomplete in the federal data. And you can find this out from the community profile reports, where each day the CDC or the HHS posts a list of all the states that have incomplete data and all the states where the counties have incomplete data. And the reason for this, it goes back to something I mentioned at the very beginning of the slide deck, which is that the federal government receives data directly from states for most states, but from a few states, it instead relies on data submission directly from a network of laboratories. And these laboratories are only a portion of all the labs in a given state. So you're only getting partial data, and in different states and territories, the problem is worse or not so bad. In Maine, you're getting totals that are about 35% lower than what Maine posts on its own dashboard. In Oklahoma, it's 79% lower. But the upshot is that, especially with the county level disaggregations, you have to be careful because you could be getting sort of an unrepresentative sample of tests. So test positivity figures, especially in these states, should be treated with caution. And the federal government has footnotes to that effect, that you should be careful with those test positivities. The other big caveat with federal testing data is that in about half of states, so 25 states, it does not line up to COVID tracking project state level testing data. And we just released an analysis of this that explains kind of the in-depth reasons behind why that we think that might be the case. We've been talking to state health officials to understand the origins of these differences. But what we've learned in a nutshell is that there are differences between the submission processes that states and the federal government use, or states use when they post to their dashboard and when states send data to the federal government. And oftentimes the federal submission processes kind of fall out of date or disrepair, and that can cause some differences between state and federal data. These are smaller differences than the ones that we see from states where the federal government is relying directly on lab provided data. It's somewhere usually in the sort of range of 5 to 20% difference between state level data. And especially with all the variation that comes with state level data, it can still oftentimes make sense to use the federal data if you're only getting a little bit of incompleteness. But that sort of leads into our recommendation of how to interact with this data, which is that you should probably, there's a lot you don't need to worry about, which is exciting. You don't need to worry about all the things that you need to worry about with CTP data, test types, test units, data dumps, all of that's sort of out the window. You don't have to think about it. The federal government takes care of it. But in its place, you do kind of need to sanity check the data. And we recommend occasionally cross-referencing with your state's top line totals and seeing if there are discrepancies there. If there are discrepancies, then it's worth thinking about potentially using state level data, depending on how dramatic those are. If there are not discrepancies, then our experience is that the historical data is generally very solid too. And we have been working to publish all our research into the cause of these discrepancies, and we hope that the federal government will do the work needed to sort of resolve these problems. Oftentimes it's just tiny corrections that are needed to get the federal data to the same place as the state data. There's a few other things you should remember when you're using this data. Remember to check the community profile reports for any data notes. Remember that there's backfilling in federal data. So if you're using a source that updates daily, like the CDC COVID data tracker, you should expect to see wiggles at the top of the time series as those tests are backfilled to the correct date. And finally, be careful with calculations like test positivity. Federal data smooths over a lot of problems with testing data, but there are still some sort of fundamental limitations of the way that testing data can be used. We released a blog post about this recently, which you can find too on our blog. The long story short is that you should treat these as ways of understanding the trajectory of COVID-19 and probably not as precise benchmarks where you can say above a 3.3 test positivity means we should do XYZ. So I think that's all for me.
Awesome. Thank you, Kara. Thank you so much. I would also just note for all the reporters on the call that despite the fact that we don't think test positivity should be used that way for all of these problems, the CDC's reopening guidelines for schools, in fact, do use test positivity in precisely that way as one of only 2 metrics, along with cases per 100,000 for when and how schools should reopen. So it's like what seem like small and very detailed wiggles in the data actually could very easily throw schools from one tier to another, or even 2 tiers up. I mean, this is kind of the level of problem that we're talking. And in fact, the CDC directly refers to that county view when they're looking at school reopening stuff. So I think if you're interested in getting into those issues, please get in touch with us. And also, that is just such an obvious real world impact in addition to many other ways that states and other jurisdictions use those test positivity numbers. I'm going to turn it over to Erin now for talking about questions.
We have questions. We have lots of questions. I'm going to try to go pretty fast. So I'm going to start with the hospitalization questions because they came in first. So Dave, you're on. There's a couple that maybe I can answer, and then Dave can tell me if I'm wrong. The first one was HHS data disaggregates variables according to confirmed or suspected COVID-19 hospitalizations, ICU admissions, et cetera. And the question was about, do we have a preference in our own data collection for combining confirmed and suspected into a total count? How we like to do that? Would we prefer to just publish COVID confirmed and so on? We love disaggregated data. We would like to see everything sliced up. We can very easily combine things. This is across the board. We would always rather see things disaggregated because it's very easy to sum. But if we only get a combined number, we can't split that up. Dave, unless you have something, I'm just going to carry on.
Yeah, just a quick nuance about that is it also depends on what the purpose of your analysis is. If you just want to know how many confirmed patients enter hospitals, that's one thing to know, or how many confirmed cases are hospitalized. If you want to know, like, for example, strain on hospital resources, you may want to combine confirmed and suspected, because as they enter the hospital as a suspected case, all the resources around PPE, negative pressure rooms, all of these things are the same. They're treated as if they have it until they're proven that they don't. And so if the purpose is for you to understand hospital strain and resource allocation issues in health systems, then you may want to look at confirmed plus suspected together. But to Erin's point, it is always better to have the choice to do one or the other or both, as opposed to what we previously had from states, which was whatever they decided to give us was what we had to use.
See, I can give you the broad answer, and Dave and Kara can give you the nuance and help you out. Thank you. There were a bunch of questions about where's the single CSV that has everything in it. And we don't have a single CSV to point you to that is a direct replacement for CTP's everything. But we do have a variety of sources of varying levels of completeness. Dave and Kara have gone through the sources that we know about. And I will say, Kara, someone asked if you could just drop a link to the JSON file that you called out into the chat. But I'm going to say that when this is done, your best move for the hospitalization data, we have a Federal Hospitalization Data 101 post up on our blog, which I bet someone else will drop into the chat. That gives you the direct links to where you can find things. We also have a very long and detailed post about the federal testing data that has a lot of that. So there's not just an easy drop-in one-to-one replacement, and I wish there was, and maybe there will be. But right now we have a bunch of things in various levels of completeness, a lot of which include many things that we don't have because we couldn't get them. I see someone was asking about, in the current CTP data set, you show a metric for new hospitalizations each day. Where are you pulling that from, and how does it compare to the facility level admissions data? We don't actually, strictly speaking, have a new hospitalizations each day metric in the CTP data set because we don't get that from states. We do have a hospitalization increase field in our API that actually speaks to the very incomplete cumulative hospitalization number. But what we really rely on from the states is the current hospitalizations figure, which changes every day, but it changes when people come into the hospital and when they go out of the hospital. So it's not the same as a new admissions metric, but the HHS does have a new admissions metric. So we use that sometimes in our weekly analysis and other places because it can tell you something different. Current hospitalizations gives you burden on the healthcare system. You can see the total number of people who are actually in beds. New admissions is going to show you something different, which is just purely who is coming in, who is getting a COVID diagnosis either before they arrive or at that time. So they work in slightly different ways. What I'm going to do is drop into the chat. We have a nice post about new, current, and cumulative hospitalization metrics, what their definitions and their uses. So that'll be a good starting point.
And I would just note the only reason kind of that we ended up tracking cumulative hospitalization, just kind of historical at the very beginning of this, it wasn't actually clear how states would standardize, like whether they would standardize on providing a cumulative number that changed every day, or whether they were going to provide this current, hospitalization number. The HHS systems didn't actually exist yet, and so it's a bit of like a vestigial holdover from those early days of chaos.
Thank you. Yes, I see a question that some states didn't have ICU numbers in the CTP data. Does the HHS data set have the missing data? The answer is yes. It's very good. I don't know that we necessarily need to go into anything beyond, like, it's in there. I see a kind of related question. CTP has a variable that counted the, as we just talked about, cumulative number of ICU patients, which has always been super incomplete. Do we know if the federal government is keeping track of the cumulative number of ICU patients or newly admitted ICU patients? I don't know of the cumulative in a federal data set. Alexis, Dave.
Yeah, no, I don't think there's no specific fields for cumulative over time ICU stays or patients in ICU beds for similar reasons why cumulative hospitalizations as a whole is a very problematic metric, which we get into in that blog post. So what is in there is new admissions in general to the hospital, currently hospitalized in inpatient beds, which are inclusive of ICU beds, and then the subset of that, which is how many patients are currently in ICU beds. And so you can use those metrics to derive perhaps, the kind of patient flow from inpatient beds to ICU beds and out of them, but there's no direct measure.
Yeah, it's not back. That's not back to the beginning of the pandemic, so you can't just add up new admissions.
Right, and you can't just add it.
Yeah, the feds have a way that you could sort of get at this. If you look at their public use like line list, they do have hospitalized yes, no as a field, and you could go at it that way. But honestly, we haven't done any data quality or sanity checks. I mean, presumably they have, but you'd be kind of on your own figuring out.
Really be careful with the cumulative stuff. It's been messy. We had a bunch of questions asking if Dave could briefly talk about the difference between the estimated time series file and the reported time series file. update frequency, relation to CTP data, and also just like which should people be using?
Sure. So there is a file in the healthdata.gov site, or sorry, a page with files in it for estimated patient impact and et cetera, et cetera. And in some ways, I believe this is also a bit vestigial from when most of the data was being reported via the NHSN system. You had facilities, not as many hospital facilities, definitely not all hospital facilities reporting data there. And so there was a need to do much more interpolation and estimation across these reporting gaps to get a sense of how many patients are in beds across the country. That file has three parts to it. There's like a overall inpatient estimates, there's an ICU COVID patient estimate, and there's a COVID inpatient estimate. It only runs the last 30 days. So it's not a complete time series since the beginning of the pandemic or any time before. It's a rolling 30-day window compared to the reported data, which actually is the full time series back to March and et cetera. And so in terms of recommendations, I'd say look at the reported for pretty much everything you need to do. You can always spot check it against the estimated. The estimated is a kind of downstream step in their data processing, and I believe the federal government does use it in some reporting that they do. But for the most part, what we've seen is that all the community and state level profile reports are pulling directly from the reported data, which at this point is as complete enough to the point that you almost don't need to interpolate these large kind of reported gaps.
Exactly. Yeah, and we've heard, unofficially, that the federal government has sort of de-emphasized the estimates through time as well.
This is probably a repeater, but could you, Dave, say one more time the frequency of the updates on the state level time series?
Yeah, right. Thanks, I forgot about that. So the state level time series is updated weekly. It's usually on Mondays, and it goes and just adds the prior kind of like 7 days worth of data to the time series, as well as backfills and corrects things that happened previously in time. And so I would say treat that as your kind of like definitive set of historical data. The state daily updates happens every single day. It's timestamped usually around like 10 or 11 p.m. Eastern time, and then released on the state update page every morning. And so this happens more frequently, and this happens almost every day. And so what you can do, and what we've done, is we've kind of taken the time series as the foundation, and we've appended the latest daily updates to the end of that if there is new data past the prior Monday, let's say. And then when the next Monday rolls around and the next version of the weekly time series comes out, we then kind of override the appended daily updates and start appending the new data to that. It's a little bit complicated, of course, and you probably want to do that programmatically, but that would be your best understanding of both the definitive sense of the time series, as well as get the most frequent updates, which is daily, from the state daily updates.
Thank you. Thanks for going into it turns out, pretty complicated answer there. Question about which hospital subsets we're seeing. How consequential is the omission of certain hospitals like VA hospitals from the HHS data? Is this a very small subset of all hospitals, or is it a large subset of hospitals?
Yeah, so I can't really speak to VA hospitals. There are a lot of VA hospitals out there. There are a lot of military hospitals and IHS facilities as well, Indian Health Services facilities. The overall number difference in facilities between the state level facility level is about 1,000 facilities, but the vast majority of them are psychiatric and rehabilitation facilities that are required to report only once a week. They're generally deemed to be lower priority in the pandemic response, and it just be kind of a overburdening them to have to report every single day. So of that 1,000 difference, I'd say like the vast majority are those psych rehab facilities, and then a minority of them are VA, military, and IHS. There may be plans to include those into the facility level data later in time. I don't know, but they're not there yet. And it's not been a big issue for us to see that. I think in general, even when we look at the state level reporting, those facilities are often not included on those state dashboards.
Great, thank you. I think this is an easier one. Is pediatric defined, e.g. by age range, like birth to 18, and standardized across states and facilities? If you mean in the HHS data, I think the answer is yes. Dave and Alexis? Okay. If you mean in the state data, it's a complete hodgepodge like everything else. I mean, pediatrics is usually has a pretty standard definition, but in general, we see age ranges all over the place. And a lot of states don't publish pediatric COVID hospitalizations broken out, or the answer is complicated in the state database, but clear in the federal database. I'm just scanning to see if we have any other hospitalization ones. Oh, one. To confirm, is there any currently available source for hospitalizations which breaks down by race/ethnicity? Are you aware of any efforts by the federal government to provide this data? And if so, are you aware of the timeline? We have seen, I want to say, a couple of states do that kind of breakdown. Do we have anything from the feds?
It's that same file that I linked earlier, the surveillance public use file, does have, I think, race and ethnicity for 51% of the cases. And the CDC also has, I don't know exactly, they have some age adjusted risk factors where you can see the increased likelihood that particular group would get infected, hospitalized, and die, which I can find while we're answering other questions.
But there's not a single place that breaks out race and ethnicity for the hospitalizations that we are aware of for all of them. Bumping down to some questions for Kara. We're linking you out to, I mean, for the ones that are just asking for links, we're going to keep linking you out to the blog posts. We're also going to post these slides so that you can click on the links and they'll be real to get to a lot of things. So I'm going to skip those. Question for Kara. I'm starting a new beat covering COVID testing on its own. What kind of data would you point to identify areas that never ramped up enough testing versus positivity? Is it possible to compare testing to vaccination? So there's a few questions in there. This is kind of a Kara Alexis question, I would say. Or I can start talking.
Go ahead, Kara.
I mean, I guess something that you could look at is this county level data in particular, I think would be useful for understanding places that haven't ramped up enough testing, because at the state level, you know, things sort of average out. In the community profile reports, one of the metrics provided is testing per 100K at the county level. And so you can see like how many tests are being offered scale to the population. Something I would say for that is making sure that you're working in a state where the testing data is generally sound, because there can be, especially like at the county level is where you also see some of the most profound effects of the missing data, because those tend to affect certain counties more than others. But if things are matching at the top line for the state pretty fairly, then I would say the county level disaggregations are also a good place to look. In terms of comparing with vaccination, I do believe the community profile reports also have vaccine data at the, I'm not sure, I haven't checked recently whether it's at the county level or at the state level, but it's in there. I guess it would depend on what kinds of things you are trying to understand about the relationship between vaccination and testing.
Thank you. Most of the remaining testing questions are actually requests for links to the things that Kara mentioned. As I said, we'll put the slides up and you can find everything. One is there a list of all labs which do and do not report, so we know how complete the testing data is? And
No
the
way.
answer is
Not even.
no. We've never had that.
You can get, so If you go to certain states, a lot of them will post their laboratories onboarding status through the Meaningful Use program, which shows the adoption of electronic laboratory reporting by, I think it's only clinical labs. So that gives you some sense of what might be going on, because the state data is what gets passed to the federal government in most cases, and sometimes the state data is restricted to electronic laboratory reporting. There are also 2 states that post lab disaggregation, so Florida and Oklahoma, I think it is. But other than that, it's a whole puzzle to figure out what labs are submitting.
I also, yeah, I mean, you could look at Florida. Florida has a bunch of laboratory lists. And the other thing that, given there's a bunch of reporters on this call, I mean, if you wanted to look into how the CDC has structured COVID electronic laboratory reporting, if you just search that CELR, there's a lot of questions, I think, there that could be profitably followed up on by different reporters.
Here's sort of a general one. Do you have a data mapping document to tie CTP data items to HHS/CDC data? The short answer is no, but the long answer is we are working through each metric and data set one piece at a time, but also the federal data is changing, in some cases quite quickly, about what is available. But we're going to give you, before we wrap up, the closest thing we can to, here's our stuff and here's everything you might use to replace it. There are some things that do not have straight across replacements. There are some things that have very close replacements. So we're documenting each of the data sets and top line metrics in these Federal Data 101 posts, and we're going to discuss a number of them on future federal data training calls. And then when we get, pretty close to feeling like we've gone through all of those and vetted everything, we'll give you a document that has the closest things, but there's never going to be a pure, metric for metric matchup on these, sadly.
Yeah, I mean, kind of depends on like the level you're looking at too. Like if we were to show you the classic like CTP 4UP, where it's got like tests and cases and hospitalizations and deaths, and then we showed it to you with federal data, if you didn't look too closely, you'd be like, oh yeah, there it is. So if you wanted to do something like that, you can still do it. It's just not going to work precisely in the same way, and the update cadence is going to be different for the different things, and it's like a little more complicated the second you sort of peer under the hood. But for a lot of the basic visualizations, particularly at the national or regional level, it actually looks pretty similar. It's just that the details are quite different.
And some of the details are big details, and some of them are small details. So, I mean, the answer is, unfortunately, it's complicated. But we do have good federal sources for a lot of these things. And we're just going to keep documenting as we go. We're still running the daily data compilation and the data analysis, and also working on the documentation. So we're kind of sprinting on as much of the documentation as we can right now. And there's also a ton of analysis that will come out after March 9th. But we're trying to get y'all, who are data users, as much as we can before that point, so that you can, decide what you want to do about your switchovers. And then I just have a couple questions here that are they're not specific to the testing and hospital data. One is the COVID racial data tracker going away as well? If so, do you have a recommended replacement? The data compilation is stopping within CTP on that data set. The data set's going to stay available as a historical data set. And we have an upcoming Federal Data 101 post on race and ethnicity data, and we'll be doing a training call on that as well, because the answer for that one is there's a bunch of stuff available. None of it is straight across. So we're going to walk you through everything that you could possibly use to try to answer some of the questions that we have tried to answer using the super messy patchworked state based data for that.
Yeah,
and then I have it.
Yeah, to that point of the link that I put in there from the CDC, I mean, one of the big problems is we haven't been able to do age adjustment. And because white people as an aggregate are older, it really frustrates a lot of the kinds of analysis you might want to do. But you can use that case file. It just has a much smaller percentage in most cases of the actual cases, race and ethnicity. So they're at 51%. For some states, we have a larger percentage, but we don't have these other kinds of disaggregations.
And then I have a question here asking about, has there been any discussion of eventually trying to integrate data on long-term morbidity, i.e. long COVID data, number of people who are currently on disability with COVID-19 as primary cause, and so on. There are a couple of states that have tried to do some tracking on long COVID in various ways, but it's been really limited, and we have not seen a substantial federal effort to go after that data. We think it's really important. We've written about that in our decision to not publish the dramatically incomplete recovered numbers that we were able to summarize from states, because they did not include all of these people who were in fact not recovered, among other many, many reasons that that was a really flawed metric in summary. So the answer is there are, I'm sure you're aware of the patient-led research work that's been happening in a few different places that's pretty easy to find, but we don't have any central federal data at this point to offer you for that. Do any HIEs provide data? Is the last question I have here, and I don't know what an HIE is. Does someone?
Health information exchange.
There we go. That's a thing. Thank you.
Yeah. So probably. I mean, to the hospitalization data. So what happens is the facilities can choose to either report directly via a system developed by Teletracking, the company, to the federal government, or a state can be certified to report on their behalf. And so the state as a whole could do that via whatever, groups or agencies they have to do that with, or they can also have their state hospital association report on their behalf. And so HIEs are probably playing a role in there. It's not visible to me or entirely clear who or what exact HIEs are involved, but I imagine they are, in order to provide the level of facility level data reporting on a daily basis in many of these states. Right, and then Kara says they also may handle the lab data for some states as well. But there isn't like a national listing of which HIEs are involved with what types of data reporting. That's the kind of the core of the question.
One other small thought on the long COVID. There are some people who'll be working with Medicare claims data, and there may be at some point some set of claims data that can be extracted to try and get at that. My sense of it is that stuff is quite laggy though, like on the order of months. So in some months, probably we'll start to see more of that.
We are now 15 past what we had planned, but we're able to get to a bunch of questions. Thank you all for staying and asking such good questions. And thank you so much to Kara and Dave for going in so much detail into these data sets. I would encourage everybody who's interested to keep an eye on the blog. We are going to keep rolling out documentation. There's new stuff almost every day. So we're just going to keep dumping everything we know onto our website, and we're going to do more trainings. So if you're already on the list, you're going to get a ping about the subsequent trainings unless you ask us to remove you from the list. So thank you all very much. And we will post these slides and probably just put up a little blog post that has the slides and the recording.
Cool. For everyone,
Thank you.
Thank you.